Hello, good afternoon. My name is Dr. Trudy Ufondun of Snowspirations Global Health Solutions. Thank you and welcome to our weekend open clinic. Today's event, it's very important because we are talking about miscarriages. And not just talking about miscarriages, we are talking about recurrent miscarriages. Now, I know it's not the best of topics to talk about because I personally love talking about positive events in pregnancy. But it's a topic we need to understand appropriately so we can know the right things to do if we have this unfortunate episode in our family. So please, thank you and welcome. Please quickly settle in, introduce your name, and also let me know your location. My admin will soon join. And once you come in, I need to know who you are. I need to know your location. Then once we have a good number, I'm going to start. So after my presentation, you will have an opportunity to ask all your questions. Now, you see, recurrent miscarriage is a very, very saddening experience. No mother wants to have this joy of anticipating the beauty of a baby, the beauty of a daughter, the beauty of a son. Then suddenly your baby is gone. It's very painful. Words are not enough to express how mothers, especially, fathers, they feel the bond of losing a baby. Fathers do. I've been there. I know how I felt, but you can't quantify how a female feels when suddenly the baby she has in her womb is gone. It's a terrible pain. Now, unfortunately, it's very common. There are so many women that will have this experience. They won't even know they have it. There are so many women that will have delayed period. And that delayed period will later come out as heavy bleeding in clumps, with pain. That can also be a miscarriage by its own merit. So it's very common. If you have gone through miscarriage, you are not alone. The fact you had miscarriage in the past predisposes you to the possibility of having another miscarriage, but it doesn't stop you from becoming a mother. So many women will have miscarriage and they will still go ahead and complete their family. Now, management of your miscarriage is what it's important. It's not just enough to have miscarriage, then you quickly wait for when your bleeding stops, then you want to try again. That's not the right approach. So what we're going to talk about today is the management, the steps, the risk factors, the likely things that might lead to this baby developing in your womb, not to continue the journey. So my admin just joined. So join me as I expose this. Then after that, you're going to have an opportunity to ask your questions. So I'm going to start. We're going to spend about 30 minutes. Now, like I mentioned, miscarriage is the unintended, spontaneous loss of an ongoing pregnancy before 20 weeks. So the cutoff point is 20 weeks. Now, if you have unintended, spontaneous loss of an ongoing pregnancy after 20 weeks, it's called stillbirth. So both of them will be loss of an ongoing pregnancy, but the demarcating point is 20 weeks. If you lose your baby before 20 weeks, it's called miscarriage or abortion, medical abortion. If it happens beyond 20 weeks, it's called stillbirth. Most miscarriages will happen early in pregnancy. Remember that pregnancy is divided into first trimester, second trimester, and last trimester. An average pregnancy is supposed to last for 42 weeks, approximately 9 months. Now, when you have this miscarriage happen 2 or more times concurrently, so if your last 2 miscarriages happened just like that, if the last 3 pregnancies ended in miscarriage, you have recurrent miscarriage or what we call habitual abortion. So we call it recurrent miscarriage or habitual abortion. They are the same thing. It's very painful. When this happens, there is a need to define the reason why these pregnancies are failing. Remember that for your pregnancy to be confirmed clinically, you have to observe 3 tests: urine test, blood test, and ultrasound. Until we see evidence that the pregnancy is existing inside your womb, you are not clinically confirmed pregnant. Unfortunately, some women will be pregnant with urine, but when they go for their blood test, the blood test will not give positive outcome. It doesn't mean you were not pregnant. It's possible you were pregnant and had early miscarriage. There are so many miscarriages that will happen and you won't even know. They are called silent miscarriage. So today we are talking about clinically confirmed pregnancy that ended in miscarriage. Now, like I mentioned, it's disheartening to watch couples go through this. And it's not just only to the couples. It breaks my heart waking up and hearing the cry of a mother telling me she bled and she lost her baby. Very, very painful. Unfortunately, it will affect about 1% of all women. 1% of all women will have this. Spontaneous miscarriage on its own will happen in 12 to 15% of all pregnancies. 12 to 15%, very, very high. So now 30% of the pregnancies lost will happen just about the implantation period and first week. That's about the bulk of the period that most miscarriages will happen. Now, it's possible that whatever numbers I'm mentioning are not the clinical picture because some women will not report their miscarriages. Some women won't even know they had miscarriage. So it's possible it's even higher. When you have miscarriage, it places you in a very dark place. Now, like I mentioned, majority of miscarriages are caused by chromosomal abnormality. Chromosomal abnormality means when your mother and your father were exchanging the genes to form you, your dad will bring 23, your mom will bring 23, then they will join it together to make you. That's 46. They might have an error. The error can come from the dad, the error can come from the mom, and we'll have chromosomal abnormality. The commonest type is what we call aneuploidy. I'm not going to bother you with the medical terminology, but just know that most miscarriages are not because of people in the village. It's not because of your past. It's just something that happens and it happens. Now, it's important that after every miscarriage, you go for checks, investigation, questioning, examination to see if we can discover what actually led to this miscarriage. Unfortunately, there is no ideal management protocol of miscarriages. There are so many schools of thought about how to manage miscarriage. What I'm going to do today is to make an attempt. So the management of miscarriage is an unsolved problem today. The management will be based on what we discovered that led to the miscarriage. So up to 50% of cause of recurrent miscarriage will not be defined. So think about that. Up to 50%, we'll do everything we can do, and we still cannot find the reason why the woman had miscarriage. Unfortunately, we also discovered that couples that are having infertility, even when they succeed in having infertility treated, some of them might also be predisposed to having miscarriage. The worst experience you will have in your life is to have long-term infertility. Then you probably went for IVF and suddenly you miscarried that pregnancy. Very, very painful place to be. We don't want it to be that. Now I'm going to talk about the risk factors. Number one risk factor, age. Miscarriages are commoner as you get older. So maternal age is an indication for risk factor for miscarriage. So once you get to that cutoff point of 35, you are classified as what? Advanced in maternal age. The reason why we give you frequent appointments to come for your ANC is because you have a high risk of having miscarriage when you are older. Any infection around the reproductive system, especially a bacterial infection we call bacterial vaginosis, is a risk factor. Some women can have cervical incompetence or womb abnormalities, is a risk factor. Some women might have poorly treated or undiagnosed diabetes mellitus, is a risk factor. Some women can have thyroid problems. So any of this can be a predisposing effect to developing miscarriage recurrently. Now let's talk about the causes. I've already mentioned the chromosomal part is the biggest chunk. Now some women can have anatomical problems. So the anatomical problems can be in the cervix, it can be in the womb. Some women will have womb that will be double. So we call it bicornate womb, Ordinarily, your womb is supposed to be this beautiful, like the heart. But some women can have bicornate womb. That's a risk factor. Some women can have infection. That can be a risk factor and can also be a cause. So vaginal bacterial vaginosis can be a cause of recurrent miscarriages. So in that event, when we discover this, we go for appropriate treatment. Now, some women can have an acquired thrombophilia. This is an immunological thing. I'm not going to bother you about that, but it's actually called antiphospholipid syndrome. This can also be a cause. Some women can also have endocrinology problems. So some women that have polycystic ovarian syndrome, elevated level of the hormones, especially the LH, or insulin resistance, or polytreated diabetes, they are all likely causes that might lead to miscarriage. Especially women can have little phase defect. So pregnancies are the cycle of a woman is divided into two phases: luteal phase and ovulatory phase. Okay, so some women can have secretory phase. So some women can have luteal phase defect. When this happens, and if it's not properly identified, it can lead to recurrent miscarriage. Now, we've been talking about women all this while. Men can also contribute to recurrent miscarriages. So if your partner's sperm is fragmented, is damaged, is poor quality, you can also have miscarriage recurrently. Now let's talk about the management. Like I mentioned, management of miscarriage, especially the recurrent miscarriage, is based on proper diagnosis. But besides that, the very first thing to do if you have miscarriage is to be referred to a recurrent miscarriage clinic. You cannot go through just a normal gynecologist. You have to go through a specialist who will take time to see what they can do for you. Now, that's number one step in managing miscarriage, recurrent miscarriage. Number two, we have to use a lot of psychology, especially tender loving care psychology approach. So we have to give psychological support to the couples, especially if we've checked everything and we didn't really see the reason why they lost their pregnancy. We have to support them. We have to continuously talk about them. We have to visit them frequently. We have to show them care. We have to be sympathetic in, giving them all the love, the care, and the tender approach. It works because stress is a big factor also in miscarriage. So if a couple presents to you, a friend, your client, or whatever, and you've run all your tests, and you can't really pinpoint why they're having all this problem, use TLC model. It works. Anxiety, it's anti-pregnancy. Depression is anti-pregnancy. Stress is anti-pregnancy. Sometimes you might not know and they can contribute indirectly. So once you are pregnant, relax. Very important. So TLC is an approach after you've gone for your consultation with a high-risk pregnancy specialist. Now, your lifestyle modification is very important. Very, very important. So you have to watch your BMI. Obesity is a factor we have implicated. Obesity is a factor we've implicated in recurrent miscarriages. So watch your body weight. Make sure your BMI is within the normal range. Don't go overboard. Don't go below 18.5, which is underweight. You need to be within the normal range. Now, definitely avoid your smoking. No alcohol. Lifestyle modification is very important. So when you adopt a healthy lifestyle when you've had miscarriage in the past, when you free yourself from tobacco, from illicit drugs, from undue stress, you are significantly giving yourself a better chance of having a very good outcome. Now, if we identify that the problem why you are having these miscarriages is because of chromosomal abnormality, there is only one reliable way for you to get good outcome: IVF. So couples we've discovered that have chromosomal abnormality, we are not going to allow them to go naturally, because if they go naturally, they can have repeat miscarriage. We will offer them IVF. So once we run our test and we discover you're having all those antiphospholipid, thrombophilia, and all those big grammar in medical field, then you need to prepare yourself and go for IVF immediately. Now, some couples that have anatomical problems. So if we discover the woman has cervical incompetence or some structural defects, if we have proper specialists that can operate on them or give you cervical sacrilege, then you will improve your chance of having good outcome. If we discover you have infection, the bacterial vaginosis, we treat you appropriately. Now, in most clinics, they will give you clindamycin. In the second trimester, it helps. So management of miscarriage, especially recurrent miscarriage, is a stepwise process. You go to high-risk pregnancy specialist. We use tender loving care. We check the chromosomes. We check anatomical defects. We check for infection. Now, also, if you have any endocrinology problems, so if you have diabetes, we need to treat it appropriately. Most times we give you what we call oral hypoglycemics, especially the metformins. If you have thyroid problems, we control that. If you have polycystic ovarian syndrome, we manage you appropriately. So what point am I making? When we discover the reason why you're having this miscarriage, we have solved that problem by 50%. Now, some women will also be given progesterone, if you notice. If you've had miscarriage in the past, we normally place you on progesterone supplementation. It has not really been proven 100% to work effectively, but we have been using it. This is an evolving discipline. Like I told you, there is no standard management of recurrent miscarriages, but we use progesterone a lot. Some women will also be given the metformin as part of managing insulin resistance. So by default, once we identify the reason why you're having this, then we go towards what we call prophylaxis. Now, some women that have recurrent miscarriages, especially if we feel it's coming from the antiphospholipid component, we can place you on low-dose aspirin and heparin. So I know some women will be wondering, why are they telling me to use aspirin or heparin or steroids? We are doing this to see if we can improve the outcome of your pregnancy. So some pregnant women currently, if you've been having miscarriages and your doctor placed you on aspirin, heparin, or steroids, they are doing it to improve your chances of having good outcome. They are all approaches to managing miscarriages. So in a nutshell, these are the few things you need to apply. So if you follow my logic, number one, once you have been confirmed to have recurrent miscarriages, remember that recurrent miscarriage is the spontaneous loss of your 2 or more previous pregnancies before 20 weeks. Don't go again until you've been referred. Unfortunately, some women are in a hurry to prove to their partner that they can easily become pregnant, then you keep losing your baby. We've actually had a case of a woman that lost her pregnancies for 9 times. And she was getting ready to go for the 5th one until we stopped her and she went for IVF and she succeeded. You do not want to lose your baby. The pain of losing your baby is forever. Unfortunately, in some women, even when we've done everything I mentioned, they will still go ahead and lose their baby. But please, let's do what we can do to prevent the babies from dying, the ones we can do. Now, the clinic is going to open, and I'm happy that also my crew are complete. So Dr. Ndiche is in the house. My admin, my COO, Kene, is in the house, and Chinyere is in the house. And Oluwatosin, can I remember to shortlist this lady for the event next week? So guys, ask your questions so I can provide you feedbacks. The clinic is open now for questions. So please, you are better off asking than assuming. Assumption in medical practice is very deadly. So if you've had miscarriage, even if it's one time, this is your opportunity to ask me questions. So please feel free to ask your questions and I'll give you feedbacks. The clinic is open now. And I also know that some medical students are in attendance. This might be an opportunity for you to brush up on your medical knowledge. So please go ahead and ask your questions. Okay. So my moderator Chinyere is asking for teaching. Okay, it's recurrent miscarriage genetic. Yeah, like I mentioned, it has some genetic inclination to an extent. So yes, if your mom, your sister, or whoever, even daughters, there are some women that will still be in their reproductive phase and their daughters are already having babies. If your daughter had miscarriage, if your mom had miscarriage and your sister had miscarriage recurrently, you might have some genetic familial component to an extent. It's not a must you're gonna have it, but it's there. So you need to be careful. Okay? What's the difference between a miscarriage and a stillbirth? Very smart question from my moderator. She's turning into a medical student. So the difference is 20 weeks. If you have spontaneous unintended loss of a pregnancy before 20 weeks, it's called miscarriage or abortion. medical abortion. If the spontaneous loss of your pregnancy happens beyond 20 weeks, it's called stillbirth. But both of them are what? Loss of your pregnancy. So that's the difference, 20 weeks. I love that question. Please keep asking your questions. I have about 10 more minutes before I go. So please ask your questions. The clinics on weekends come a little bit early. So on Tuesdays, 12 a.m. Nigerian time, 6 p.m. Eastern time US, but weekends we come a little bit early. So weekend is 6 p.m. Nigerian, 12 p.m. Eastern time. So please keep asking your questions. Keep asking your questions, please. We're talking about recurrent miscarriages, and I'm going to make my transcript open after this so you will learn better. Okay? Don't go for another pregnancy until you've seen a recurrent miscarriage specialist. Ask. Don't be in a hurry. Some women will not even go for evacuation. The retained products of their baby is still in their womb, and they go about becoming pregnant again, and they keep losing their baby. It's painful to lose your baby in things we can prevent. So please don't try again until you've seen a high-risk pregnancy specialist. How soon can someone try after miscarriage? You have to touch base with your provider. So anytime you see bleeding in pregnancy or low back pain or water coming out of your body, it's possible you're having what we call threatened miscarriage. So you report to your doctor, we examine you, we can probably place you on admission, then we monitor you. The fact you had all these symptoms doesn't mean automatically you're going to lose your baby. But if unfortunately you end up having complete abortion, that means all the babies left your body. Or if you're having complete abortion, we need to, get everything out. So you can expel it by yourself, or we give you some drugs, or you can go for evacuation. Once you have been confirmed healed from your provider, then you can proceed. So some women can, start as soon as 1 month, 2 months, 3 months. So it's individualized. So run it by your doctor, and your doctor will be the person to guide you. But you need to go for follow-up. Yesterday, I had a lady that had miscarriage on the 31st of January, and she was already gearing up to go for another one. And I told her, you need to keep your appointment. So you keep your appointment with your doctor. We run everything we need to run. And please don't go by yourself. We've seen so many women who will quickly go to the lab to run some ultrasound. Then they look for doctors to interpret it for them. That's not a right approach. Always use your doctor. Don't take yourself to the lab by yourself. You are wasting your money and resources. Let the doctors be the people that will make the call, ask for tests. Then when the report comes out, you take it back to them. Okay? All right. Can consuming certain food lead to miscarriage? Not directly, but indirectly. Okay? Now, if you have problem with your BMI and you're eating carefully and your BMI is still high, you're in the obesity range, obesity is also already a known risk factor to developing miscarriage. But there is no one particular food that once you eat, you begin to have miscarriage. I know where you're coming from. Some people say, pineapple, this, that. There is no evidence in support of that. Now, we have some drugs that once you take it, your baby will come out within 1 second. So don't go there. There are some people that actually take it behind, the door. They want to abort their babies. They go about it. There are so many people that take so many nonsense. There is a particular drug I will give you now, and your baby will come out within 1 second. That's a medical indication. The only time in medical practice a doctor can comfortably opt for miscarriage or medical abortion, it's when the life of the mother is in danger. So if we are battling between the baby and the mother, we always go for the mother because she can be around to have another baby. That's the only time there might be an indication for medical abortion. But please do not ingest anything you don't understand into your body. They might not cause the miscarriage directly, but they can indirectly lead to other things that can happen behind the scenes and lead to miscarriage. Very good question. I love that. Okay, now my COO is on the floor. What kind of tests are to run to determine the cause of recurrent miscarriage? So there are some genetic tests. So there are some specific genetic tests we can run to see if we can discover this antiphospholipid stuff I mentioned. Definitely, we have to rule out infection from the bacterial vaginosis, run ultrasound, check the womb. So any of those points I mentioned that might be a risk factor or a cause. So if it's chromosomal in nature, we run genetic tests. So you go for genetic tests. We run a couple of panels to see what's going on. If we are suspecting infection, then we run a panel to rule out bacterial vaginosis. If we are suspecting structural problems, then we go for radiological evaluation, ultrasound, MRI if need be. Then if you have endocrinology problems, we rule out PCOS, we rule out diabetes, we rule out thyroid problems. So the investigations are based on our need for them. So once we have from our history and we develop a track, we feel that this is the direction the things are going, then the investigation we're going to do will be tailored towards that avenue. Most of the investigations are not routine investigation. Like if we're trying to rule out antiphospholipid syndrome, it's not all the labs that can offer that. So we need to go for advanced investigations. Very important. I love that question. What can a woman having recurrent miscarriage do differently so as to have full-term pregnancy? Number one, you have to attend all your A&Cs. Definitely, I've already mentioned the lifestyle modification. Take all your ANC medications. Avoid smoking, avoid alcohol, avoid stress. Take all your vaccines. If you can do all this. Now, if you have any ongoing medical problems, hypertension, diabetes, or whatever, you go for your clinic, we manage you appropriately. Keep an eye on your weight. Make sure your BMI is within the normal range. We treat you for malaria and a couple of other infections, then you're good. So ANC is very important. Lifestyle modification is very important. Avoid stress, avoid anxiety, avoid anything that will place you in a negative place. Then when you do this, and God being on the throne, you will become successful. Very, very cool questions you guys are asking. You have a sister, she has contractions, she's 6 months, she's placed on bed rest, Island Hospital. She told me, okay, so here's the deal. If you are having contractions before 37 weeks, 37 weeks is stem. That's called preterm contractions, which is a precursor to going into labor. So normally when a baby is getting ready to be born, the womb will start contracting to push the baby out. Now, if this contraction happens very early, before 37 weeks, there's a problem. We need to stop that contraction. So your sister did the right thing by going to the hospital, bed rest, highly indicated, place her on a couple of drugs. These drugs are going to give her, is not like, oh, once you give you, everything will stop. Some of those contractions will die up by themselves. Now, some women can have fake labor, which we call Braxton Hicks. Okay? Now, 6 weeks. You don't normally love using months in pregnancy, but 6 weeks means she's actually getting ready to give birth to this baby. So if we have good facilities, a baby at 6 weeks can be born and the baby can be fine. We'll send the baby to the NICU. So your sister is doing the right thing by reporting to the doctor, going on bed rest. Now, there are 3 things you must do once you have problems in your pregnancy, especially bleeding, or if we suspect you're going to have miscarriage. No sex, no sports, no stress. 3 S's: sex, sports, stress. Avoid it as if your life depends on it, because truly your life depends on it. So your sister is doing the right things. Now, there are a couple of things they will do to your sister. Number one, about this period, because anytime we suspect that pregnancy can end, we want to walk through a protocol that will give us a good place to be. So one of the things they will do for your sister is to make sure they give your sister steroids to mature the lungs of the baby. There are stuff that help the baby to breathe properly when the baby is outside your body. They are called surfactants. Now, if your sister is in this position, they will manage your sister and give her a couple of steroid injections so that if the baby decides to come early, the baby will have a better chance of surviving. Can low quality sperm lead to miscarriage? Yes, I already mentioned that. If the male part of the equation, it's an indication, we check the sperm. Some men can have defective or fragmented sperm. So poor quality sperm can also be a factor in recurrent miscarriages. So the answer is yes. Okay, so guys, I have 1 more minute. Now, if today is the first day of attending my clinic, thank you so much. I hope you subscribe. If you haven't subscribed, click the subscription button. Make sure you like the comments. Make sure you share the page. Check other videos. There are so many videos that will help you to know better about your body in the group. The name of our group is Snowspirations. We are in YouTube. We are in Facebook. We are in TikTok. TikTok is really going crazy now. We are having fun there. We are in Instagram, we are in Twitter. So there is no place you go to, you won't find us. Now, remember, today I have another event it should be my 2 p.m. I think it should be your 8 p.m. in Nigeria or thereabout. Make sure you attend that event. Contraceptives and conception. Don't miss it for a thing. Now, tomorrow I have another clinic, but there's a big event coming up on the 27th, a symposium. How can fertility be connected to your lifestyle and your love life? So lifestyle, love life, and fertility. We're going to go there. It's highly recommended for all women to register for this event. So I'll see you guys tomorrow for our regular clinic. But until I see you, okay, I think I have another question. What can be done to prevent recurrent miscarriage? Chinyere, I've answered this a couple of times. So all the panel I mentioned, tender loving care, checking for genetic, checking infection, checking the endocrinology, resting, doing all that, taking your precautionary measures, they are all steps towards managing recurrent miscarriages. I think I actually started from there. Okay, so thank you for coming this afternoon. My time is up. I'll see you guys again on Tuesday. So Tuesday clinic, 12 a.m., 6 p.m. Eastern Time, US, but 12 a.m. Nigeria. So I'll see you guys again on Tuesday. And until I see you, take good care of you. And please register for your ANC once you are pregnant. If you're looking for a baby, you can find help in our organization. We have a couple of packages. So if you need to talk to me one-on-one, you can leverage on that opportunity. But every member of this community that wants to be a mother will be a mother. Becoming a mother is a choice. You can be a mother at any age. Any woman can be a mother at any age. It's how you become that mother. Okay? God bless you, and I'll see you in a few hours. Bye-bye for now.